So welcome back, and in this session we're focusing on MRD as a surrogate endpoint in multiple myeloma. So it'll give us an opportunity to explore the current state of the evidence for and the challenges in using MRD as a surrogate endpoint. We're going to try to apply some of those framework issues and criteria that we discussed earlier this morning. To kick it off, we're going to start with a presentation by Ola Landgren, Professor of Medicine at Memorial Sloan Kettering. He'll provide an overview of the current state of the evidence on MRD as it relates to multiple myeloma. And after that opening presentation, we have a panel of 5 members who will share their perspectives and insights about this topic. After that, we're going to open up for a bit of discussion across the panel and then comments from all of you. So I'd like to again thank Ola for kicking us off today. We'll then hear from Nicole Gormley, the acting clinical team leader at the Division of Hematology Products at the FDA, then Nancy Valenti, the Vice President for Global Product Development for Oncology at Genentech, then Daniel Auclair, Senior Vice President for Research at the Multiple Myeloma Research Foundation, Richard Little, Senior Investigator, the Division of Cancer Treatment and Diagnosis at the NCI, and Autinia Herring, the President and Chief Executive Officer at Cancer Research and Biostatistics. So over to you first, Ola.
Thank you very much for those kind words, and I would like to thank the organizers so much for inviting me. It's really a great pleasure being here today. So I'm going to talk about multiple myeloma. Can you please put up my slides? Or I do one more? Okay. So this session focuses on multiple myeloma, use of MRD as a surrogate endpoint in multiple myeloma. And the way I've structured this presentation, as you can see on this slide, has 3 components. First, I will give some brief current evidence to support the role of minimal residual disease in clinical trials for multiple myeloma. The second part of my presentation will focus on some scientific, practical, and regulatory barriers that I think we need to discuss. And then also I will shed some light on next steps, and I have inserted some of my personal opinions on that last part. So to start off, for present evidence to support the role of MRD in myeloma, we have just completed a meta-analysis. It just came out today in the journal Bone Marrow Transplantation. It's available online. The methods for this paper, in brief, summarized on this slide. We conducted a systematic search for clinical trials in collaboration with the National Library of Medicine at the NIH, and we applied searches in Medline, Embase, and the Cochrane Central Registry for Controlled Trials. A total of 390 potential studies were first identified, and these were carefully reviewed manually. And as we heard during the morning presentations, there are a lot of rules to do meta-analysis, and this was done, as I pointed out, in collaboration with the National Library of Medicine. So taking this approach with a defined script that's outlined in this paper, 370 of those papers, after we have gone through them carefully, did not meet the pre-specified criteria. So only 20 studies could be used. It was conducted using a random effect model that carried weight for the larger studies, contributing more to the overall hazard ratio. And they were combined on a scale of a logarithm of the hazard ratio and the corresponding standard error. When these 20 studies were further reviewed in full detail, it turned out that 4 of these studies included allogeneic bone marrow transplantation. That is a very uncommon treatment for multiple myeloma, for those of you who do not treat patients with myeloma. And these patients were not newly diagnosed, and the intent of this study was to focus on newly diagnosed patients. Looking further into the literature, 7 of these studies also had to be excluded because they were clinical reports that said that patients treated with this or that therapy had X% MRD negativity, and on this other arm they had another % of MRD negativity. But for the purpose of a meta-analysis, one has to have access to hazard ratios and confidence intervals, and those were not reported in these clinical papers. 4 papers also had to be excluded because there was overlapping information, meaning that they used the same cohorts of patients, but they had restricted them to some subsets of patients within these clinical trials. and one study was excluded because the timing of MRD analysis was not specified. So here you can see in a graphical way what I just pointed out. So there were 4 studies that were included for the purpose of this meta-analysis. And I probably should point out to you that multiple myeloma impacts around 30,000 Americans every year. So it's not like colon cancer, breast cancer, prostate cancer, or lung cancer. On the flip side, because patients are living quite long and we do not have an established cure, we have around 100,000 people living with multiple myeloma. So this disease imposes a little bit of a different challenge than the scenario when you can have very large studies and many studies. So with these 4 studies, we were able to study the role of MRD negativity in relation to progression-free and overall survival. 3 studies had used multiparametric flow cytometry, and 1 study had used allele-specific quantitative PCR to determine MRD status. These methods, although they were slightly different, they had at least the sensitivity of 10 to -4 to determine MRD status, meaning you could rule out 1 cell in 10,000. The largest study provided about 60% of the overall weight, and the smallest study provided about 2% of the weight. As highlighted in red on this slide, the overall progression-free survival in relation to MRD association had a hazard ratio of 0.35, meaning that you reduce the risk of progression by 65%. And that's illustrated on this slide in a graphical manner. As you can see on top, the smaller study that only provided about 2% of the weight for the overall estimate, the hazard ratio for that study was 0.10. And I point that out particularly, I was involved in that study myself, and this is a study that was published last year in JAMA Oncology. That is the most modern therapy we have in the United States at this point. And as you can see, there's a 90% reduced risk of progression. So the reason I point this out is because when we have larger studies, usually they take a very long time, and they are not reflective of the therapy we use in the clinic today. For the purpose of overall survival, there were 3 studies that did have overall survival information. The largest study and another study from the same country, they both came from Spain. Also, the study that I just mentioned where I was involved myself had information on overall survival. But because very modern therapy was given, none of those patients had passed away. So you couldn't use that study to study overall survival differences in relation to MRD status. The correlation between MRD negativity and overall survival had a hazard ratio of 0.48. So you reduce the risk of dying by about 50%, or 52% to be exact. And that's what this slide shows you in a graphical manner. So in summary, what I've showed you is that this meta-analysis, with its inherent caveats for this particular disease, shows that MRD negativity is associated with a better progression-free and overall survival in the setting of newly diagnosed multiple myeloma. There are ongoing studies at this point in the United States, in Europe, and in Asia, studying the role of MRD negativity. And these studies, because they're ongoing, we don't yet have information. We had 1 larger study presented at the ASH meeting, the American Society of Hematology meeting in December last year, and we anticipate to have further updated information in the upcoming annual meeting. In very brief, this is a study that was presented at ASH using a 3-drug combination, and as you can see on the left, patients continue with that same drug combination, and then they were put on a drug called Revlimid for 1 year as a maintenance therapy. On the right, after they had received 3 cycles in the middle, they went to autologous stem cell transplantation and got additional 2 cycles and then maintenance. So this study was designed to compare modern drugs versus old chemotherapy with transplantation. The study was designed to compare the 2 arms, and it showed, the results showed that the transplantation had a longer progression-free survival, so that arm won. If you look in further detail, you see that the progression-free survival was 61% versus 48% between the 2 arms. Now, the reason why therapy lasts longer is because the depth of the response can be shorter, deeper or less deep. And in fact, you can see that the transplantation arm had 58% of patients obtaining a complete response, while the non-transplantation arm had 46%. So the longer progression-free survival was driven by the fact that more patients obtained a deeper response. Now, if you put these two arms next to each other and you look at those patients that reach an MRD negativity, and you draw a line and you see how long their progression-free survival was, you actually see that if you reached MRD negativity with either of the two therapies, the progression-free survival was the same. So that tells you or suggests that if you have a disease subtype that responds well to the less aggressive therapy, that may be good enough for you. I do think I see a lot of patients myself. I think the field of myeloma probably is going to change in this direction. Major scientific and practical regulatory barriers that we have in this disease. We have for a long time been lacking standards, and that's what we heard this morning. A few weeks ago, we had a publication that took care of this dilemma you see on this slide. On the left, you have flow cytometry, and on the right, you have sequencing-based MRD testing. There has been a lot of discussion whether you should use one or the other because they have different sensitivity. Just a few weeks ago in Lancet Oncology, the myeloma field published this document, which is published in the name of the International Myeloma Working Group, and it points out how to determine MRD negativity in multiple myeloma across studies. This is not the first International Myeloma Working Group guideline we have published. We have done this for several years now, and for every iteration, we have improved the response criteria. We started off with unified definition of complete response. We added something called stringent complete response, and we now have moved forward to determine MRD negativity in multiple myeloma. The way we define it in this disease is that we require the patient fulfills the criteria for complete response as previously defined for many years now. And in addition, absence of abnormal clonal plasma cells in the bone marrow with an assay that has a sensitivity of 1 in 10 to minus 5, or 10 to 5, or 10 to minus 5. So that means you rule out one cell in 100,000. And the way we have written these criteria is that you can either use flow cytometry or you can use sequencing, as long as you have a validated assay that can deliver a sensitivity of 10 to minus 5. I think this is a huge step forward, but there is still also remaining uncertainty in this field. So one of them is, what's the role of sustained MRD negativity? In this document that I am talking about, the International Myeloma Working Group criteria, beyond the definition of MRD negativity, there is also a statement saying that one can use in papers and in studies a terminology namely sustained MRD negativity. And that's defined as you repeat it, and you have to repeat it at least 1 year apart. You can also do it repeatedly beyond that. You can say the patient remains MRD negative, for example, at 5 years. But we don't really know clinically to what degree that impacts the long-term outcome. I would predict, as a doctor seeing a lot of patients that do maintain MRD negative over years, they probably have a much better outcome. But there is less data on that very topic from larger studies. We are trying to study in our clinic at Memorial the role of maintained MRD negativity. And we use this also to study mechanism of patients that either stay MRD positive, and we try to use that to find new ways to treat them, and also for patients who become MRD negative and then turn MRD positive again. We are using that for treatments. These are unpublished data that we have just reviewed. I used to work at the NIH for 10 years before I went to Memorial. Here is information on MRD negativity that is sustained. And you can see in red, in a series of patients that we treated with modern therapy, that we obtained MRD negativity in 44% of those patients. You can also see that after 1 and 2 years respectively on maintenance, that those patients remained MRD negative. So with modern therapy in this disease, we can have a lot of patients reaching a very deep response, and they can maintain MRD negativity. At our institution, we probably see between 300 and 350 newly diagnosed patients every year. So in 3 years, that's 1,000 patients. I have many patients that I have followed for years that have been MRD negative repeatedly. I now start seeing patients that are MRD negative for 5 years, and they come and ask me, do I have to stay on therapy? And I say, I don't know. I offer them to either continue, or if they want to go off, and I keep on monitoring them. So far, none of those patients that have gone off had relapsed. Unfortunately, I think there could be patients that will relapse, but this is an open question for now. We know for patients that are MRD negative, if they turn MRD positive, it takes on average, based on this paper, 9 months. In my clinical experience, between 6 and 18 months for patients to start developing symptoms. So that raises the question whether we should think about MRD conversion back to positivity as an indicator for early therapy. I personally think that patients that are being diagnosed today probably have an overall survival of 15 to 20 years. And if we treat patients early on, they could even live with the disease without having a lot of symptoms, which is a completely new scenario for this disease. PET-CT is another area of uncertainty and is in these new guidelines. But I would like to point out a couple of points with regard to PET-CT in myeloma. It has a lot of false negative, probably 30%. False positive is very high. The definition of how to determine SUV positivity is not clear. The timing for when to do PET-CT is not clear. And also, FDG is not really an ideal tracer for myeloma. There are a few more uncertainties. MRD negative newly diagnosed patients versus MRD negative relapse patients. Does it have the same value? High risk versus standard risk biology. Does it have the same value? And what is an acceptable MRD level? I want to end my talk by showing a few more last slides for next steps. I think there are practical steps, and then there are future steps. The practical steps is to make MRD an endpoint for myeloma. And from my horizon, looking at this disease for several years, I'm quite sure that MRD will become a regulatory endpoint for myeloma. I think of it as a surrogate endpoint that could lead to accelerated approval and then lead to a full approval, and that's what we heard this morning. It has to be done the same way for every patient with complete follow-up. Additional homework will be to establish the optimal time point for MRD negativity, and also we need a trial-level MRD difference between the study arms, as we heard earlier this morning. Lastly, future steps. Could we use MRD to modify therapy? I think we will, and I think we're going to do that very soon. And in fact, we have already almost started doing that. For patients that we see in our clinic, we give them combination therapy, and if they are MRD positive or negative, we guide them forward. If they are negative, we offer patients either to go to maintenance directly or to go to transplantation. And we are not sure that transplantation really makes anything better in this setting. Maybe save that for later. For patients that are positive, we guide them to go to transplantation, and sometimes they go to additional therapy before. Could we use it to stop therapy? I mentioned I have patients that ask me that. I don't know the answer. We are studying this. The last thing is, what are we thinking about going forward? I think the field is going very, very fast. Patients are living longer. We have very many new drugs. They are much better, much less toxic. I think we need to get out of the bone marrow biopsy business. We need to have tests that are blood-based or urine-based. So I'm going to be a little bit provocative and end my talk. I think we need tests like this that show patients who are MRD positive or negative. And if they call us in the middle of the night, we say, check again tomorrow and call me during business hours. But I do think this is what the patients would like to see. So I'd like to thank you so much for your attention.
Okay, thanks a lot. Next is, for coming, is Nicole, and I think if you all feel comfortable just sitting, you can do your presentations from there. So Nicole?
Yeah, great. So I'd like to thank Ola and the organizers for inviting us to participate, and I'd like to thank particularly Ola for his presentation. I think it really touches on where we are currently in the area of multiple myeloma with minimal residual disease. I think there have been a lot of advancements, and I think this has just been exemplified in and congrats to Ola for publication of your meta-analysis. But I know that the meta-analysis that Ola Landgren's done and also that that Nikhil Munshi have done have really added a lot of information and in this area. We're seeing, and I think consistently, there's been a demonstration that there's a correlation, a strong relationship between MRD and attainment of MRD negativity and long-term clinical benefit outcomes that we're interested in, such as progression-free survival and overall survival. And I think these advancements are really critical. I think the juncture that we're at right now, though, is really trying to understand and consider how to best use them. So additionally, just I want to echo some of the comments that were presented earlier by Dr. Jen Dickey and Dr. Vishal Bhatnagar, that these are really, in the agency, there are scripted processes which we evaluate a surrogate for ultimate use in clinical trial designs. And it's really important, and when we're considering a surrogate endpoint to be used for clinical trial design and regulatory actions, there's a high evidentiary standard, and that's really critical that we have that, just because the potential harm that could be introduced if we incorrectly used a surrogate. And so to avoid those potential pitfalls, there really has to be a high evidentiary standard. There has to be confidence in the assays that are being used, and we have to be able to really have confidence that we're what the surrogate is purporting to tell us is actually accurate. And so because of that, I think where we are currently, there's a lot of still unanswered questions. And Dr. Landgren's already pointed out some of these questions and outstanding issues. But I think from a regulatory standpoint, I think some of the issues that we struggle with and grapple with, again, are what threshold is really needed to be predictive of the ultimate clinical benefit endpoint of overall survival or progression-free survival, et cetera. There have been various studies that Ola has pointed out that suggest, deeper is better, but then what threshold is actually best? And if we are only achieving deeper levels of MRD negativity with greater toxicity, does that really still hold up in the end? And so I think that's something that we really have to carefully consider. And then additionally, when you're comparing two therapies, we really need to know what treatment difference is really indicative of clinical benefit. And I think that's an area that we haven't really necessarily looked at, but what margin of difference is really indicative of a clinically significant, meaningful difference with a therapy. And then additionally, there's still a lot of just unanswered technical questions. There's been a lot of advancement in the area of standardization, especially with the recent publication of the IMWG criteria, but there's still a lot of heterogeneity in terms of what actually is assessed and how it's assessed, et cetera. And while the agency is agnostic to the specific type, as long as it actually is analytically valid and purports or describes what it actually does, that's okay. But there still needs to be a firm understanding of what we're actually assessing. And then I think some other outstanding questions pertain to also the disease setting, whether or not the same benefit exists if we're looking at MRD in a relapse patient population. Most of the studies thus far have been done in the stem cell transplant setting, and there's been some standardization in terms of timing of assessments in that disease setting, but we really don't have clear indications about looking at MRD in a relapse refractory patient population or an elderly population that's not eligible for stem cell transplant, and what are the appropriate timings of those assessments. And then, as Ola mentioned as well, do we need to look at sustained MRD? There's been some data on that as well, but that's been recently published by PAIVA, but we, I think, need to have a little bit more understanding around the sustainability of whatever the MRD response that we're measuring as well. And then I think as well, some of the other issues pertain to the role of cytogenetics. There have been a lot of studies in MRD in myeloma in particular that have really shown that cytogenetic high-risk patients have worse outcomes despite attaining MRD negativity. And then just how do we incorporate that in terms of when we're looking at MRD assessments then? And so I think there's been a lot of progress that's been made in terms of standardization and really sort of evaluating the relationship between MRD and ultimate, clinical endpoints of interest. But I think that we still have a lot of unanswered questions, and I think there's been examples that we can look at from other disease areas in terms of how to address and answer those questions. And I think we've been the agency is very open to working with and engaging with the community on this issue, because it's something that's very, we realize is really going to be important moving the field forward. But I think there definitely needs to be collaboration, I think, to really achieve these goals in the most expeditious way possible. So with that, thank you.
Great. Thanks very much, Nicole. Nancy?
Yes, I also want to thank the organizers for the opportunity to participate in the panel, and I think Nicole's made a lot of great points. We've made a lot of progress in multiple myeloma, and patients are really benefiting from that, living longer, and there's a lot of new therapies. But at the same time, they're still not cured, and there's a lot of unmet medical need. So I think there's great room to advance the field with novel or surrogate endpoints like MRD. And if you think about in 2016, that to conduct a clinical trial in frontline multiple myeloma requires almost 1,000 patients and probably 5 years to read the outcome, that's a long time for patients to wait. We've been talking about two major concepts so far, and everybody's talked about that. MRD as a surrogate or novel endpoint for clinical trials, and also MRD for treatment decision-making for individual patients. And I think we need to distinguish those and separate those. And I'd like to focus on the novel endpoint because I think that's where we can make a great advancement for patients now. And then we can use that information to further individual treatment decisions for individual patients. And you've heard Ola or Dr. Landgren talk about the evidence, the meta-analysis that shows that obtaining a deep response or getting to an MRD negative state correlates with a long time in remission or progression-free survival. And I believe the entire multiple myeloma community believes that relationship exists. So when we go back to Dan Sargent's earlier comments about we need to start with a biologically plausible relationship as well, I think we're there. And really, to me, it's the tool, using this as a tool in a clinical trial is a different bar than using it to make treatment decisions, right? Because in the clinical trial, we're trying to establish the relationship of this early endpoint to a time to event endpoint that occurs later. And by doing so, we should be able to determine if these new therapies are effective earlier. We could save lots of time in development, and we can get these to patients faster. And as was previously said, we can use, I believe we can use any tests that we analytically validate. This was described earlier, the analytical validation of the assay. And I believe it doesn't have to be perfect. So we don't have to measure perfectly every compartment in which myeloma exists. We just need to establish a compartment which then correlates with the longer-term outcome, right? It would be a tall bar to say the surrogate has to measure, the extramedullary space, the bone marrow, the blood. It has to incorporate a PET scan, a bone marrow, peripheral blood. We've been able to do this both in CLL using peripheral blood as a surrogate, being able to show the correlate between the bone marrow and the peripheral blood. Obviously, in multiple myeloma, that's going to be tougher because the disease isn't in the circulation to the same degree. But my point is really that I don't think the surrogate has to be perfect to establish the relationship that we need to accelerate drug development. And I really, as Nicole said, and also Ola, we need to work together as a group, ensuring that in all the randomized phase 3 trials, consistent methodologies used to measure MRD, whichever methodology, and we also have progression-free survival endpoints, and then we can further establish that relationship. But I think we also, as a community and with the regulatory authorities, need to take a leap of faith, right? We should be ready now to start thinking about using MRD as an endpoint in clinical trials, maybe a co-primary endpoint where we both take a risk together. saying the biology's there to establish this relationship. We could get the accelerated approval on MRD and then come back with the PFS. And then we need to be willing to say, if we don't establish that relationship, if it's not true, we'll withdraw the drug, right? But I think we have to take a bit of a leap, because I think if we wait for the perfect meta-analysis with meeting all the statistical surrogacy, we might be waiting a long time, right? And in between, we can generate that data. A great example is the leap of faith that was taken with pathological CR for breast cancer, right? So the meta-analysis did not reach formal statistical surrogacy, but it was felt that given how long it takes to develop new therapies for adjuvant breast cancer, then maybe, and to be able to introduce new promising agents, there has to be some other endpoint that we can use to explore this. So I'm hoping we can actually apply something like that across all the hematological malignancies. Thank you.
All right, thank you. Daniel?
Well, and thank you for the invitation. It's always a pleasure and honor to be here with all of you. So I'd just like to go back. I don't know how much it's been obvious, the amount of progress which has happened. At this exact same meeting back in 2013, there was so much squabbling around this perceived lack of standardization. Look where we are now with the IMWG having added MRD to the response criteria. And by the way, I like very much what was done. We did not enforce a specific assay, but we went for sensitivity and reproducibility with whatever is a good assay. And I think that's a great path. So the next step is, obviously, it's going to be very important. We've heard from Dan Sargent. These meta-analyses is really a way to move forward. But I suspect we will be asked for more data. I don't know why, I'm just saying that. I'm sure the biostatistician will have a field day once we're done talking here. But but put together, the good news is the FDA has shown us a path forward. This collaborative process, like what was done in PAT-CR for breast cancer or CR30 in follicular lymphoma. So we have a path forward here, but as these efforts have taken some time. Fortunately, I think we can be faster. As Dan Sargent mentioned earlier, we've become much more clever with the way we do data aggregation and data analysis, and I think especially in the last maybe 12 to 18 months. Driven directly or indirectly by initiative that sparked out of PMI and Moonshot. So I think we will be able to do this much better. And more importantly, I think we have to be much faster. In myeloma, as well as in other cancer, it's important to hit as hard as possible, as early as possible. And we have already great drugs that the regulators have provided us in later relapse disease. It would be great if we could move some of them upfront faster, or maybe move new combination faster. So we need to figure out a way to make this happen that won't take another 5-10 years. So we've realized all of that, and about a year ago we started an initiative in collaboration with the FNIH Biomarker Consortium and under the stewardship of Dr. Ken Anderson, where we've put together a broad coalition where we had key opinion leaders, academic collaborator, FDA, industry, advocacy groups, and patients. And we've put together this effort where we hope to get, we'll have a white paper coming out in the very near future, but really to put this coalition together to get this kind of collaborative effort going with FDA, with all of you. It's important. The time is now, and we need to make it happen.
Thanks, Daniel. And next is Richard.
Thank you very much. I'm very pleased to be here, particularly with this esteemed panel. And you know, I have a great interest in MRD and hematologic cancers for the same reason that I think everyone else does. The potential for using it in clinical trials to inform how we treat our patients, the power of that really cannot be overestimated. And the data that we have in multiple myeloma thus far shows that it is absolutely, without question, a very strong prognostic marker. Patients, as we have seen in the analysis, who have an MRD negative state, regardless of their therapy, do better than patients who have MRD detectable disease. That is the definition of prognostic biomarker. Whether or not it will become a validated surrogate marker remains to be seen. What we need is data where we look at the effect by treatment arm in randomized trials on the MRD status in each treatment arm, and how does that then predict the ability to say, well, that will translate into the desired difference in progression-free or overall survival. And I think that it's clear, however, that it is part of a response assessment. And so for accelerated approvals of drugs, if a overall response or a very deep response is a means by which one can have an accelerated approval, I think that MRD can be part of that. Although I would offer a caveat about using that as a sole endpoint of interest, because sometimes driving a patient into MRD may be associated with greater toxicity. I think John Bird raised this issue earlier, that later on there may be adverse consequences to certain therapies that initially looked very promising. So I think if there's a race to the bottom to try to get drugs approved, it really is important to consider that down the road there could be adverse consequences, particularly when one is thinking about combination therapies. And so we have these very, very potent combinations of proteasome inhibitors and antibodies, some of which have been associated with cardiovascular toxicity. Combine them with anti-CD38 endothelial targets, you could end up having additional toxicities where the MRD would have suggested that this would have been the better therapy, but longer-term follow-up would place things into more of a balance. So I think although everyone wants to quickly get to an answer, replacing the long-term, carefully designed clinical trials apparatus with short-term endpoints would be a potential grave mistake that would endanger patients. I'm not saying that it's not an important tool. It is. It can be used. But we really have to think hard about thinking of this as a surrogate marker. The surrogacy for progression-free and overall survival has not been established. One of the slides that we saw looking at the Dana-Farber IFM novel therapy versus transplant showed improved complete response rate and progression-free survival in the transplant arm. The overall survival is absolutely no different between the two arms. And so, to me, that allows advice to a patient who might not want to go through the rigors of a transplant, that your life is just as well off going with the more modern therapy. We can take care of you over a long period of time, and you'll have the same life expectancy. And so, if one were to rush to the bottom with MRD, you could potentially throw out drugs that could achieve a long-term treatment effect, but you would have thrown it out based on MRD alone. So that's my caveat about using it for drug development.
Great. Thank you very much, Richard. And next is Antia.
Yeah, thank you. Thanks for inviting me. I actually made a couple slides. Do you have them? So I just wanted to go back to what Dan Sargent so nicely explained this morning by the definition of surrogacy, that it must be a correlate to the true clinical outcome, and it must also be fully capture the net effect of treatment on all mechanisms of action on the clinical outcome. And I think we're getting close, right? There's definite evidence for both, but it hasn't been fully proven. Next slide, please. So, as the statistician, I sometimes look at these slides and I felt like I got to give a cautionary note. When we display or analyze data by a future measurement, such as overall survival from the start of therapy by MRD that's measured later on in treatment, and that inherently may bias the outcome and may make the differences look larger or the effect larger than it actually is. If you could continue slide. I just thought a picture says 1,000 words. Mm-hmm. So this is total therapy 3 data from the Myeloma Institute at the University of Arkansas. And the first graph shows overall survival by CR. So everybody in the blue curve has a CR or achieves a CR at some point, and the effect looks really large. But do keep in mind that patients in the blue curve first have to live until you measure CR. So inherently in the red curve, you have patients who die before they even get their CR measured, right? So it makes it look the effect a little larger. And the next graph, that's what I call a properly landmark graph. That's we look at 6 months in this case. Is the patient, of all the patients who are still alive at 6 months, patients who are in CR versus the ones who are not in CR, and you see the effect is just smaller. And that's the same for that you would see in MRD, and then these others are 12 and 18 months landmarks. And then if you could continue to the next slide for me, please. This one just shows a really extreme example, and that's rare. That's a subset of total therapy 3 patients of the in ISS stage 2. And there is the effect actually goes away. So just keep in mind that can occasionally happen. So in the next slide, you can see the slide that Dr. Landgren showed earlier. And whenever I see these long bars, right, that indicates a little bit that there may be a landmarking issue. Now in this case, so again, we'd have MRD positive and negative from a start of therapy. In this case, I'm not so concerned because it looks like MRD status is measured at the same time, right around 12 months. If you look at it, you probably can't see the x-axis, but right around 12 months, that's when it looks like MRD positivity and negativity is measured. And if you landmarked it, it probably wouldn't look very different. So I'm not as concerned with this one. But the next one, Ola, if you wouldn't mind, that's one. If this was properly landmarked, we would likely see a smaller treatment effect. And what I mean by that, the depth of response, the light blue curve on the top, you can see that has a long, long bar before the first event happens. And that's about 2 years in. So it really, to me, it looks like, and I'm saying that just looking at the graph without having analyzed the data, but to me it looks like what this graph mostly shows is that it takes a long time to achieve a deeper response, like the black curve, right, the 10 to the minus 3 status, that happens like maybe within, 6 months or so. So I just want to encourage you to ask your statistician to landmark their analyses. So properly, this would have been maybe MRD status or sensitivity at a certain landmark at like, say, 12 months. And see what it looks like. We just want to make sure we compare apples to apples. So, little cautionary note from the statistician. Thanks. And yeah.
Okay, thanks, Antia. It's a really good discussion that you all have engaged in already. I'd like to spend a few minutes asking if there are any reactions or further comments from the panel based on what you've heard, and hoping that you could particularly focus on a couple of things. One is going back to Ola's original comment that we're not there yet in terms of evidence on surrogacy in multiple myeloma, but we'll get there, I think was what you said. And we heard some of the cautionary notes from Richard, from Antia, others about the quality evidence so far is not at the level of the sort of the gold standard that Dan described earlier. So what can help us get there, get to better evidence faster is the kind of collaboration that Daniel described, likely to materially and significantly impact the generation of evidence related to surrogacy, and what's good enough evidence in this context. How do we adapt what we've heard earlier to the specific context of multiple myeloma? And Ola, maybe I'll start with you, since I expect you have a few reactions to what you've heard since.
Well, first of all, I would like to say, I think we are stuck in old thinking, and it's based on old therapies and old drugs. So think about cancer just 10 years ago. Most cancers were treated with very toxic drugs, and there are still a lot of cancers, so survival, unfortunately, is very poor. So now we're talking about myeloma. I see a lot of patients, we see a lot of patients at our center. I would say 75% of patients that come to us obtain a complete response, and 2/3 of them are MRD negative. They're going to live for 15 plus years. This is reality. This is 2016. So I do think the old thinking that effective drugs were toxic is no longer true. I think effective drugs don't have to be toxic. And I do not share the perspective that the new combinations are causing a lot of toxicities to that degree. We are not pushing so hard so patients have to turn MRD negative. I think going forward, I think this is the only way forward. We are not going to have new drugs approved for myeloma if we don't get MRD as an endpoint. So I think the way forward, in my opinion, would be that the drug companies that have ongoing or just completed trials, that we work together, and I propose that we pool those data sets and we do these analysis that we have discussed this morning, and we just put it together. And that would be the way to kind of make MRD a valid endpoint.
Thank you. Other comments? Richard?
Well, I am old, Ola. But, you know, as I said, I think that in order to establish MRD and myeloma as a surrogate for a true endpoint, we need to have the properly designed clinical trials that look at the treatment effect on MRD as well as on the true benefit endpoint. And we need long enough follow-up in those clinical trials to get that data and to also look at all the potential adverse events and toxicities long-term. And we need to do a number of trials like that, and we need to do this in collaboration with all the stakeholders, including pharma companies, to conduct the large randomized trials with sufficient follow-up. And as we have heard, there is really an independence on the kind of agents that you're using and the degree of surrogacy. So surrogacy may apply in one set of circumstances, but not in another. And so this, in my view, is not something that you just say, we're done, it's a surrogate, and you move on and then do everything based on that thereafter. That can be very dangerous. And there are multiple examples in medicine where that was done and proved to be dangerous. Antiarrhythmia drugs, for example, that were shown to decrease the arrhythmia that was thought to be the cause of death in patients with cardiac arrhythmias, were initially approved on their basis of being able to decrease the arrhythmias in randomized trials, and so the drugs were approved only to be shown in longer-term follow-up that they were associated with greater risk of death. And so while the drugs that we're using in myeloma are much, much, much better and less toxic, at least in the short run, you don't ever know, particularly with chronic administration of drugs, what's going to happen longer term. And so I think not having that long-term follow-up in clinical trials is potentially dangerous for patients. And I do think that getting drugs out there earlier so that we can include them in the appropriately designed clinical trials would be an asset. So I do agree with you there.
It does sound like there is agreement that that there should be more efforts to pool data across the different clinical trials, enabling the conduct of the kinds of meta-analyses that we talked about earlier. And Nancy, Daniel, I'd like to hear from you on, is that happening? Could more happen? And any other comments you've got on what you've heard?
So I'll let Daniel talk about what's happening. But I want to say that I think we would all agree on the panel and the entire myeloma community that we want to develop drugs that are safe and effective for patients. We don't want to put anybody at risk. But I think there's a compromise, or not a compromise, there's a place where we can very carefully and thoughtfully bring new therapies forward by using the accelerated approval process. So there is a process in place where when we see therapies that have very promising early outcomes, I think we can have discussions with the regulatory agency. And I think they have approved agents or use the accelerated approval path. We saw this earlier, a bunch of new therapies with overall response. And if you think about MRD as being a deeper measure of overall response, even beyond CR, which it looks like it predicts for very prolonged remissions, beyond what you could predict just with a clinical CR, I think there is a path forward. And along the way, I totally agree that we should be pooling all the data, working together across the pharmaceutical industry, in the entire community, and the entire multiple myeloma community, further developing this surrogate. But I think if we wait for that, so if we need more frontline clinical trials to prove the surrogacy and in transplant eligible and ineligible, and in those relationships, I would assume we're talking about like 5 to 10 years from now. Daniel?
Well, thanks, Nancy. So yeah, I think the way the group is thinking right now is if a meta-analysis could be performed rapidly, aggregating already existing data, and I agree with Rich. Rich likes to be disruptive, and I agree with Rich that eventually you would need to further validate then that marker in ongoing longitudinal studies. But I think there is a path where both can be done, and this is where we're working. There are different groups, whether ASH or MMRF or IMF or different groups have ongoing activities to start pooling that data, but we're really on the verge of getting into an effort to put all of that data together.
Ola, you had one further comment?
I'll have to tease a little bit with Rich. So Rich and I used to work together for 6 years at the NIH, so we know each other very well. Well, so I, of course, agree that it has to be safe, and I'm sorry if it was not clear enough. It has to be safe, but my point is that we can deliver safe and efficacious drugs today, which is different from what we could do just a few years ago. And I think the words we're using are very powerful. When we say surrogate endpoints and we say true endpoints, it almost sounds like the other ones are not true. I think those are things that I'm actually quite sensitive to that. When I hear a patient coming to me saying, I was diagnosed 10 years ago, I was told at high risk, and I think about that all the time. That breaks my heart. I would never present information to patients like that. And I think when we talk about these things, these are so important things. So using words like true and surrogate, to me, those are very strong words. I just want to kind of bring that up, that the words kind of bias us in a way of thinking. And I think we should put the data together and we should do pooled analysis and see what the data shows.
Okay, there does seem to be strong consistency in views on that point. Yes,
Can I make
Nicole?
one comment? I feel like one thing that I feel like we really need to sort of reconcile is I feel that we really need to figure out how to use the tools that we have. And I just want to point out the pathologic CR example has been brought up a couple of times, and I think there are a couple really interesting aspects and I think that we can glean from, and that particularly the purpose of that group. It was, as you mentioned already, it was very collaborative, and that there was industry, there was academia, the FDA was involved, so there was widespread collaboration involved in that example. But then additionally, really, I felt like the questions that they sought to answer were not just, what is the surrogacy per se, but really looked at answering some of the outstanding questions. And that, they also were there were multiple definitions for path-CR used at the time. And so, that investigation really sought to say, what is the best definition that we should be using? Is it, just axillary, or is it, tumor size, et cetera? So they really sought to define the disease as well. And I think that example really if there could be collaboration in this area, I think, to allow us to answer some of the outstanding questions that we have with MRD and multiple myeloma. I feel like at this time we don't really have, we don't really know how to use it. And I think that we have the potential, if there is collaboration, to really address some of those issues.
Yeah, that really was a strong example that was able to follow through effectively on the issues that it raised. So it was a good point to make. We have time for a couple of questions from those of you who are here. Yes, go ahead and don't forget the microphone.
Great, thank you very much. I really enjoyed the presentations by all, and I just wanted to make a quick comment about some of the potential limitations and some of the opportunities, to be honest. The limitations that we might think about is that, we're blessed in myeloma. I think it's now 18 FDA approvals in 12 years. It's going to continue, fortunately. So the treatment paradigm keeps changing. So therefore, a lot of the other things change. The categorization of high risk is now changed. The kinds of therapies we use, from transplant to therapies that could be called targeted, to now immune therapies, that's changing. What I'm getting at is that these way we diagnose and treat myeloma is changing, and even more, the way we measure MRD is going to keep changing. In the past, it was PCR. Now it's sequencing or multicolor flow, and someday it might be single-cell sequencing and cell-free DNA. So why I say that is we're always going to be limited when we do meta-analyses of data, that it's not ever going to be totally current in the era, in myeloma and other cancers too, of all of this progress that's happening. That's the happiest problem we've ever had. We never worried about MRD and myeloma because we couldn't achieve it. How do you like that? So now we can. And my comment is just this, and maybe, Nicole, you could comment on this, or others too, but being old, as Rich kindly commented, I remember when we didn't even know what response meant in myeloma, and Velcade came along. And now what are we going to do? We actually have some complete responses with this new drug, but we don't know what it means. And so the FDA was incredibly prescient at the time, and a number of people worked together. And the issue was transplantation. High-dose therapy showed that getting a complete response really mattered in terms of clinical benefit and outcome. And so the FDA, in a very prescient way, in my opinion, said, okay, it's transplant day, it's not a new drug, but nonetheless, it's CR showing an outcome. So we're going to use CR as an endpoint for accelerated approval. And I won't go through all the rest, but eventually PFS was used as a regulatory endpoint, and it's resulted in all these approvals over the years. So what I'm getting at is, when the need is urgent, we're a victim of our own success. Getting a new drug approved in upfront myeloma is virtually impossible now until we have some kind of a metric at, I'll make up, 12 or 18 months that can predict for clinical benefit a lot interval later. We can't wait for that long interval. So the question we have among us on the floor here today is, how much data do we need in order to make, I won't call it a leap of faith because it's actually based on data, but we need to, as a community, on behalf of patients, decide that we are going to do this based on whatever meta-analysis we have, maybe with some more data that industry and others can provide in a collaborative way.
And we are going to have to wrap up. So
all right. Well, my wrap-up is, it's an important comment, though. I really think that in order to continue the progress, we really need to make a decision in the relatively short term, either to do this or have a plan for getting this done in the really, in the next short interval, not long term.
Well, Nicole, that idea of like working together on a plan is kind of what you were talking about a minute ago. Yeah.
I think there are, and the agency has, I think, as you pointed out, demonstrated in multiple myeloma and other heme malignancies a good deal of flexibility in terms of, I think we recognize the importance of MRD across the heme malignancies, and the CML example that was presented earlier as well being an example where we are now to a point where we can use MRD for regulatory actions. And I think, it's going to require, and I keep saying this, but I think it's going to require collaboration and people working together. I think, we are on the cusp of having the data that we need to really answer these questions. Now there are other, there have been recent evaluations looking at MRD in other settings, the relapse refractory setting. There's been other data as well that's been generated recently that I think, once we combine this in a way that, and with everyone's input, that really could allow for us to answer all of these remaining questions. And we're not there yet because we don't know, actually, I don't feel, how to use MRD at this point. We don't know what thresholds. We don't know when you're comparing two therapies, what's a meaningful difference between two therapies. But I think that we actually have the potential to really work together to answer these questions, and I think it's going to require multi-group collaboration to get there.
Nicole, I think that's a great comment to end this panel on, and I appreciate the spirit from across the panel on doing what you said to generate that collaboration and get to better results. Thank you all. Thank you all very much. All right. And we are going to move right into our next panel, so I'd like to ask all of the next panelists to come on up, and we'll get started with that.